give you a few directions, introductions, and then we will go into our question period, which I will ask the panelists questions. If time permits, we will take questions from the audience. I believe earlier you were given colored sheets of paper. They're on your tables. So if you have any burning questions as the discussion is going on, please write those down, and we will try our best to address some of them. I don't think we'll have time for all of them, but we'll try to get some of those questions in. I will start with our first panelist, which will be to my left, and I will ask her to please give her name, her title, and her organization affiliation, and then we will go into the questions.
Good morning. My name is Katherine. I have the pleasure of serving as the Executive Director for an organization, listen up because the name is quite long, the Coalition for a Tobacco-Free Arkansas. It's a pleasure being here.
My name is Stella Lowe, and I'm a retired dietitian. I'm the founder and the president of Lifestyle Ministries, which is a medical mission organization that serves HIV/AIDS people in West Africa.
Good morning. My name is Odessa Darrough, and I am the president and CEO of Innovative Lifestyles for Senior Living, a nonprofit organization whose ultimate goal is to provide innovative lifestyles for individuals to live a longer and healthier life.
Thank you very much for those introductions. I believe we will start with Mrs. Stella Lowe, which is with Lifestyle Ministries. Many factors can affect how quickly HIV infection progresses to AIDS. Factors such as age, co-infections, ethnicity, geographic location, genetics, infection route, which means how the disease was transmitted, nutrition, pregnancy, stress, and whether or not the patient smokes or uses recreational drugs can affect the rate at which an HIV patient develops AIDS. In addition, the healthcare provider's experience treating HIV can influence how quickly the virus progresses. My question to you, Mrs. Lowe, is, as an HIV nutritionist for over 20 years, what factors have you witnessed? And please take your time.
Accessibility to care. Here in America, it's so easy, for you to get in your car, come see the dietitian.
The mic.
Oh,
Thank you. Thank you.
Accessibility to service. Sometimes it's very difficult for the patient or for the client to come and see the dietitian. Once they get there to see the dietitian will sit down and tell them what it is that they have to eat, what it is, how they have to cook the food. And most of the people that I work with don't have the wherewithal to get the food. So the availability to what I'm telling them to eat is also a problem. Now they might get some food stamps, which usually will run out like in a week or two. So they don't have the food. And we know that malnutrition will really make a person be more susceptible to other diseases, which eventually will get them into opportunistic diseases that will just get a person to be seeing, to be facing AIDS. So getting there to see the dietitian, getting the food that you're supposed to eat, and having sustained care, sustained food to be able to do that, to keep yourself from getting infections, it's always a problem. Now, sometimes when you see the client, not only does the client have the HIV problem, they also might have something like diabetes. So then the food, the way you tell them to eat is going to be a little bit different from just having the HIV. So all these things can, be a problem for somebody that's trying to, live with HIV/AIDS.
I have a burning question as far as nutrition is concerned. Are there any negative foods or any positive foods that an individual that is infected should eat? Say, for instance, fried foods. We know for people that have high blood pressure, fried foods are not good for individuals that have the high blood pressure.
When you are dealing with somebody that is hungry, that is malnourished, I just want them to eat. I just want them to eat. I don't care if it's donut for breakfast, if you get it, eat. Now, if this same client has problems with heart disease or has problem with diabetes, then I'll cater whatever it is, the treatment that I've given to that problem. So if they are diabetic, I'm not going to have them to eat, fried chicken every time. But if they are poor, they don't have the money to buy the food, and Aunt Esther brought them some fried chicken, please eat it. Because when a problem is like that, you just try to feed the person to get what the sustenance they need. Now, if a patient has, hypertension to go with it, of course, there are some things that we can tell them not to eat, like bacon or sausage and stuff like that. But if they are hungry and they haven't eaten all day, and please go ahead and eat it. We are trying to survive.
Thank you very much. Please pass the mic along. We have a newer member of our panel to join us. We would like for her to give us an introduction. Tell us who you are and who you are affiliated with, please.
Well, my name is Damita Marks, and I'm affiliated with the community itself, period, because I am part of the community. I was asked to come to talk about HIV and AIDS and how it affects the family, and I'm excited about sharing that with you.
Thank you, Mrs. Marks. And since you have the mic, I have a question for you. We know that difficulties exist with individuals who are infected and affected by HIV. Please share, if you will, 2 experiences that you have had as an individual affected by HIV.
2 experiences.
2 experiences. And please take your time.
Thank you. Whoever said that, thank you very much. You can't hear me?
No.
Well, 2 experiences. One was with my son who contracted the HIV and AIDS, while he was in jail. He called me one day, he was out of state, and he just talked about, Mom, I got something to tell you, and he was just so, just overwhelmed with it. He just didn't know what to do with it. His mental well-being was really weak, and his mindset was just, he was confused. So when I got a chance to see him and we talked about it, and he told me, I'm going to die. I'm going to die. I said, what is it? I know you're going to die because I'm going to kill you, And one of the things that when he said, Mama, I got AIDS. And one of the things that you don't ask when a person has AIDS is, how did you get it? What was the first thing come out of my mouth? Well, how did you get it? Is you gay or what's happening? I didn't know all that. And I was surprised, I really was, as a mother, but I needed to know just for my well-being, because you just done laid something on me that I got to deal with. And to deal with that was not going to be silent. It wasn't going to be with shame, and it wasn't going to be in denial, because that was the first thing that would kill me. Those 3 things right there. For him, he's looking for help. All he can see is a death sentence. And he didn't tell, he said, I don't know. He said, I don't know how I got it. And I'm still harping on, are you gay? Not really, he's not gay. But he's been incarcerated several times. He has a tattoo around his neck where they use shanks and stuff to make that tattoo. Not making excuses either. But he's a bisexual young man, to my knowledge, anyway. And if he was strong enough to tell me he had AIDS, he would have told me that he was gay. You know, I feel that strong about it. But I talked about that shank. I can remember when he first went to prison how AIDS disguised itself as TB, and they weren't sure about what it was a long time ago because he never did get a chance to say I have AIDS. I mean I have HIV. He found out he had full-blown AIDS, so he missed his HIV session. So what happened then is I go home, I flip-flop and cry like I'm gonna die and worry about a family and where I'm going to get money and stuff from like that. But, you know, after I finished with that, I said, hold up, Damita, hold up. This is a task that you've been given to deal with this child. You didn't bring him this far, and you're not going to take responsibility for his actions. You're going to hold him accountable for them. And so I did. First thing I did was I learned about HIV and AIDS. I became an HIV and AIDS counselor, tester, outreach worker. After that, I educated him and my family. He didn't like it. He didn't want to hear it. He didn't want to talk about the T-cell count, how low it was when his was 200, and how that's almost a death rate, you know, back then for him. He didn't want to talk about it. He didn't want to talk about any of that things. But I stayed 24/7 on him and family with education, educating them about it, educating myself about it, crying about it. Why me? Why me? And this is some of the stuff that I went through, the mental, emotional stress. First of all, I've always said that I'm not the person to give an ulcer. I mean, I'm not the person to get an ulcer. I'm going to give you one before I get one. So that's what I was fighting against, not to make myself sick. Anything that had to do with HIV and AIDS, I worked with. I worked with him day and night. He'd come home drunk. He'd come home on drugs. I still worked with him. Tough love. It is not easy. It is not easy, but I refuse to have a secret. The secret would have killed him alone. He's still doing fine with AIDS right now. You know, so it wasn't a secret anyway. It was open. He had it. And I had to go through the whole 9 yards of mental repairing his mind for his mistake. I told him you weren't born with it. You can either live with it or you can die with it. That was my experience. It was not easy. It took a lot of prayer. It took a lot of going against family morals and decisions because they didn't want to hear it either. Nobody want to eat after me. Well, I don't want to eat after you. I'm still struggling with the stigmas on HIV and AIDS. So get over it. Let's do something else. You know, get you a plastic food and fart. I mean, I was at the point to where I was not going to let him die from HIV or AIDS. I was not going to let him just kill himself because he could have. Once he got more information as he was incarcerated, I'd send him information every week incarcerated. I'd send him information about blacks and HIV and AIDS in prison. A good sabbatical. That's what I called it. You on a sabbatical, so you fixing to learn something now. And he began to learn. I began to learn. We began to put it at rest and peace within our family. And we deal with it in the community one by one. He knows what he has. Do you know what you have? I can sneeze and he can catch pneumonia. Do you know what you could catch if I sneezed on you? See, I mean, this is the way you have to put it. You really have to stand steadfast. That was the first experience, and that's a short example of it. The second experience was when he has a son. I wanted to know, did his son have HIV? Did he contract it from his dad? Unprotected sex. I got on the phone, called the baby's mama, and said, you need to test my grandson for HIV. His daddy has it. You think that was easy? It was not easy. It is not easy to even sit here and talk about it with you. But it was something that had to be done. If I'm going to save my family, if I'm the head of my family, if I'm going to live and be a role model for my family, I'm not going to let my family die with shame. I'm not going to let my family die with shame. And that's what we have to do as family members. We've got to be willing to look at this from a perspective. My son told me, when he told me he had AIDS, that he could not make responsible decisions because of the drug and alcohol problems that he has. His addictions could not let him make sound decisions. So as his mother, and in his 20s, I helped him with those decisions. He had no longer the decision to say, I'm going to keep my AIDS a secret. That's a hard blow. That's a hard blow. Taking the responsibility from him to save others, because he has a sister. What if someone else do for him what you would want somebody to do for you and your others? It's basic living. It's basic living. And be willing to change and accept it. I'm not dead. I'm not ashamed. I can't say that I'm proud, but I can say that I'm proud of him living with it now. I can say that now. I couldn't say that before, because all he wanted to do was live and just constantly spread. He brought a girlfriend home one day. I said, well. He really tested me. He really tested me. Do I sit and just keep this a secret? Do I keep this a secret? What families keep it a secret today? What families keep that a secret today? A whole lot of them. If you do not speak now, you'll speak later on. It may not be even in his generation. It may be in his son's generation. In order to break a cycle, you start with yours. You start with yours. The cycle breaking begins with the individual that understands. That's where it goes, right there. So I went up to his girlfriend and I said, did you know my son has AIDS? Oh, I had to catch her eyes. They almost popped out of her head. I don't know what you're doing with him because I don't like him myself. You know, if I tell you to run, you better run. I'm his mom, and I love him. I said I didn't like him. That's a difference. It's a difference. He calls me now. He writes me now. He's still in prison. He still says, I'm doing well. When he found out that the medicine matched his chemistry in his body, he learned his body better. He can tell when his T-cell count is low without even having a test. I'm not feeling well. The least little thing. I used to send him magazine information. Stay away from cats. They carry this and they carry that. He runs from animals. Once he was educated and know that he has a family behind him, he's okay. Now he'll say, Mama, you had to toilet everything. Well, you told me you weren't responsible, so I had to take responsibility. It's just like somebody with a disability. Who's going to manage their money? Who's going to manage them with a disability that they're not able to do? When he's dealing with drugs and alcohol, he hadn't even accepted those issues yet. How am I going to break the cycle for his child that's at Fayetteville right now majoring in biology? How am I going to do it? Stand up and speak out. You asked me for 2, I gave you 3.
Thank you, Ms. Thank you so much for sharing. I'd ask that you pass the mic along to Mrs. Darrough that is sitting to your left. And we know, Mrs. Darrough, that you are a representative from the faith-based community.
Yes.
It is a fact and often said that outside of Christianity, it is difficult to openly discuss interventions in the church. And I may not be saying this correctly, but I believe the word says, for lack of knowledge, the people perish.
Yes.
So my question or questions to you are, how difficult is it to openly discuss HIV prevention in the faith-based community? And what barrier is one likely to encounter with either discussion?
You are so correct that we will perish for the lack of knowledge. That's why it's so important that we are informed, educated, and thus become empowered. And as far as the faith community, it's been well documented that HIV, as far as informing the public and helping with the situation, the church has an integral role, a very vital role. In order to reach out and partner with the faith-based community, we first of all must build trust. We must let the congregants as well as the leaders know that first of all, we love you. Love is the key. We're not there to judge. We are there to partner with and to assist and be a partner in changing the situation. The mention of HIV/AIDS automatically conjures up this sexual behavior, this we don't want to talk about situation. And the best way to deal with that is first of all, get to know the faith-based community, get to know where they are. Don't try to change or to come in with your program immediately. Take baby steps. Get to know what is going on, what best suit that particular congregant and their membership, and follow suit based on where they are, where they would like to go in baby incremental steps. Once you establish that you are there to assist and whatever they are willing, if you go in with the mindset that I'm going to present this program, they need to take this and they need to do, that's going to be a barrier that says, I don't need you in our situation. All of the things that you're trying to do will be for naught because first of all, it's a two-way street of communication. Go in with the understanding that we are here to partner. Let that leadership of that congregation and the congregants take the lead. You there as a facilitator to assist them. And if you do that, you are more apt to get the cooperation and the desire to learn more. So many of the leaders, faith-based leaders, have a desire to want to do, to know they should be there, but because of the lack of knowledge and information on how to handle that, they back away. Because they are there more as a spiritual leader, not as that leader in a care for the HIV/AIDS patient and their families. So take the time to determine where they are with their desire and take it from there. If you do that, the desire is there to learn more, and then you'll have an opportunity to step in baby increments to lead the way to bigger things beyond the faith-based area as far as the church, but into the community, because it's a holistic approach of not only inside the walls of the church, but the community as a whole in informing, educating, and empowering.
Thank you. This next question will go to Mrs. Katherine Donald, so if you could pass the mic down to her. Mrs. Donald, studies suggest that smoking does not influence the rate of HIV disease progression. However, there is good scientific evidence that HIV patients who smoke tobacco are more likely to develop certain opportunistic infections and diseases. Opportunistic infections occur in individuals who have weakened immune systems. As a leader in tobacco prevention across the state of Arkansas, and knowing how detrimental tobacco use is, how would you approach an HIV-positive individual who smokes to encourage quitting?
Thank you for that really good question. When I think about tobacco use in itself, I know that there are terrible health implications that comes with smoking and exposure to secondhand smoke. But then when I think of the combination of smoking and an individual or individuals living with HIV/AIDS, that combination is a tremendous health impact. I heard just earlier this morning from Dr. Smith when he talked about the importance, I believe one of his, near the last slide that he showed, the negative impact of smoking and impact that it does have interfering with the drug combination of drugs that individuals take for treating their HIV disease. When I think about both things, for me, if I came across an individual and they are HIV and they are also a smoker, I would definitely take my time to try to talk with them, share information so that they would be informed, number one, about the dangers of smoking. Probably I'm preaching to the choir because more than likely they already know that. We know that most people who smoke already know that it's dangerous, but it's the nicotine that has them addicted, so we know that they're dealing with a habit. So to not ever being a smoker myself, I would be as empathetic as I could possibly be, not ever being a smoker, but certainly empathetic with them and the struggle. I would share with them that they're on a combination of treatment of drugs for this disease that they have, and they have a desire, I know, to live with it, and they want to live a healthy life. And they can do all that they can do in their own power to live this healthy life. And one of the ways they can possibly do that is through smoking. Giving them the information and being in the trenches with them to become empowered to make the decision for themselves, because definitely I cannot make that decision for them. I can preach to them all day long. I can share information all day long. And believe me, if I thought it would make a difference, I would do that. But first of all, so bringing information there, letting them know about resources, about quitting. Most people think, well, I want to quit, but I can't afford to quit. The patches are too high, the gum is too much, albuterol and whatever else is out there, just causing too much money. So people are just searching for what can I do. I would make them aware, number one, there are resources inside of the state. Number one, the Arkansas Quit Line is a free resource that's funded throughout state tobacco control dollars. That's a resource available to you to help you quit the habit. We know that if you quit smoking and you have a support system in place to make you more successful in your quit attempt, your drug treatment regimen that you're on for treating your HIV disease is likely to work better for you. We know that smoking in itself weakens your immune system in many ways. We know that it does impact you. The four major cause preventable disease comes from smoking. Number one, heart disease, cardiovascular disease. We know COPD and stroke. We know those things, and those often things that are preventable. We know that people who are suffering with HIV, many of them, not all of them, have lung conditions like some type of emphysema, very similar to an emphysema-like condition, and that's for the individuals who smoke and non-smokers. Well, if you think of your immune system being weakened, the likelihood of all of these diseases that can possibly happen to a quote healthy individual that happen to be a smoker, and then you're going to combine an individual who's now living with AIDS in that recipe. That is a recipe for, and I'm using my word, for a health disaster. We saw earlier the amount of money it takes to treat an individual for 1 month. If we catch it in the early stage and they're a little sicker, it's going to be almost $2,500. In the later stage, we know that an individual is going to cost a lot more per month just to treat their HIV. So you would want that canvas to be as clear, as clean as possible to give you the best opportunity for your meds to work for you. And if you introduce smoking or tobacco use into the equation, you're interfering with your drug regimen. So to give yourself a fighting chance, a real good fighting chance, you would want to do that. I believe most people would, and I'll have a dialogue with them very similar to this. I just believe you would. I know it's not going to be an easy thing here for you, but there's help for you, and if you will allow us to help you, we are here for you. And to follow up on that, my office is, for the last 18 months is across the hall from a health clinic, and this particular health clinic treats a high population of individuals who are living with HIV. I didn't know that when our office moved there to the location we are in now. But one of the first things that I did do, I went over and I introduced myself to the physician's office, and the assistant at the front carried over a supply of fax back referrals for anybody who wanted to quit smoking and say, hey, here's a quick free service. Please direct people who want to quit to our office. Lo and behold, just a month ago, an individual, a gentleman from Hot Springs, Arkansas, who has to travel to Little Rock every month for his treatment. He's living with HIV/AIDS, and his doctor for the last 2 years have been talking to him about quitting because his drugs are not working for him. And the doctor is telling him, one of the reasons I believe that your drugs are not working to the best that they could possibly do is because of the smoking. So this day, about a month ago, the gentleman came across to our office and said, hey, I heard that you can help me get some help quitting, and we connected him to the quit line. But what we also did do is say, hey, here's my number. If there's anything we can do to help you further, please let us know. And then I'm going to stop, but I do need to put out this caveat. As we identify individuals who are living with AIDS, and they happen to be smokers, and we do want to get those individuals to quit. But I also believe that from the depth of my heart that once you identify a person and they have a need, it behooves us to have a place to send that person when they have a need. You know, you have a need, and I have nothing to do with other than to say, oh my God. What I believe we can do, we can lift our voices and let the state know that monies need to be put into our tobacco prevention program so individuals who want to quit will have those resources available to them to quit. If you saw the news yesterday, you now know that Arkansas has a decrease in its tobacco prevention monies, and part of those funds fund our cessation program, the Arkansas Quit Line, if you will. It went from last year, an $11.5 million funded program. This year, the funded program for everything, not just a quit line, but for everything, is $7 million. It's less than 25% of what is recommended by the Centers for Disease Control that a state-funded tobacco program of our size in Arkansas should have. So I'm saying to you, we can help individuals, we should have resources for them, but if we don't fund our programs, we won't have a place to send individuals. So that's my soapbox. So,
thank you, Katherine, so much. Now, we've heard from our panelists, but we want to hear from you. So does anyone, I think we have enough time to take at least 2 questions. Does anyone out there in the audience have a burning question that they would like to ask one of our panelists?
Ms. Marks, as far as the prison system is concerned, you talked about your son being in prison, AIDS in prison and stuff. Did the prison system have anything to offer him as far as once he was diagnosed with AIDS?
He went in the prison system with it, and yes, they do have they have doctors and things like that. A lot of the inmates don't utilize the service because they don't want to be ostracized by the other inmates knowing what they go in to see the doctor for. My son didn't have an option on that because I wrote the warden. You know, when you know what you're dealing with, you have to be creative of the other person's because you love them. That's because I love him. After he realized that I wasn't letting up off of it, he's began to be better with it. You know, he's a lot better with it in prison. And an acceptance with it. He knows to people that just enter prison, that comes from the streets, they carry a lot of germs and infections that have been dealt with yet. He knows how to stay away from those till that is dealt with. But yes, it's ways that can be dealt with it. Family has to take some responsibility.
Yes.
Family has to take responsibility. They have a role if they want to have a family.
I got a question for you, Ms. Mark. Did you see smoking stools down there affect your baby? Smoking?
Crack cocaine smoking slows it down, and just like she said earlier, it does interfere with your meds. I had to teach him about that. You know, alcohol, crack, all of that. He had to understand how that interferes with his regimen that he was taking, because he would take medicine for a while and quit. And once you quit, you can't take that medicine anymore. You have to be re-examined for a new, what they call it, a cocktail. He thought he wasn't going to take no more cocktails, but he was going to take some. So I worked with him. He had a really good doctor that was totally devoted, a young doctor that was totally devoted to AIDS, and especially AIDS among African American people.
What about your weight? You said, just mentioned about weight. If you type 2, like type 1, type 2 diabetes, I know they have to watch their weight. I'm a type 2 diabetic. So what would be the weight range that they're about to see in line with?
Now, as far as the diabetes and that kind of thing, I'm not sure about. Maybe one of the other ladies. Thank you so much. I'll let her have that. Ask me something else.
If a person is diabetic before the person is diagnosed, they would have been on a diet before, they started the HIV diet. But anything that you do to improve the diabetes status is the same thing you will do for HIV. It's done a little bit differently. Now, if the diabetic person came in with a lot of weight, we know that too much weight will not be good for your joints, will not be good for the diabetes, it won't be good for your heart. So the dietitian will sit down and come up with a diet, not so much to get you to lose so much weight, but to control the diabetes. There is a way to control the diabetes by watching your carbohydrates. And if with the carbohydrate counting, you can do that, control the diabetes. You will lose some weight, but it won't be as dramatic, so that you'll be able to take care of the HIV too. With some HIV patients, they come in with a lot of weight. You still want them to be healthy. So you tweak the diet a little bit so they can lose some body fat and keep those things that are good for them, good protein source, and let them lose some fat. Exercise is crucial. Exercise is crucial. And if you are diabetic and taking HIV medicines, if the HIV is in control, the diabetes, is also better. If the diabetes is better, the HIV count is also going to be better. So they go hand in hand, because we now believe that they all have some impact on inflammatory, diseases. So if you control one, you control the other. You have to kind of control your weight by exercise and by eating low-fat diet. Not too much to lose too much weight for somebody that is HIV. Although some HIV people need to lose some weight because of cardiovascular diseases. So it can be done.
Thank you. Let's give our panelists another round of applause, please. I know that we probably have many more questions, but because of time, we are not able to get to those questions. But I encourage you, I'm not sure how long our panelists are going to be with us today, but if you have a question that you would like to do something one-on-one with them, I'm pretty sure that they don't mind addressing those questions with you. But I want to leave you with this thought and piggyback on what Dr. Nate Smith said as he was up here speaking. What do we do next? We need to get tested. We need to get HIV people into care. Make HIV care more accessible and affordable. That's a big one. We need to make HIV care more holistic. And then we need to all work together toward a cure. Thank you.
All right. We'd like to thank our panelists, and as we always do, we like to give people their flowers while they're still before us. And we present our token of appreciation to our presenter and moderator for the panel, Ms. Johnson. And we also would like to present to our panel.
Thank you. And I think I kept it on time.
Oh, you did a great job in that.
Thank you.
We need to give you a lunch ticket and make sure before you exit the door.